Hello, my name is Michael Nicastro, and I'll be talking to you about the relationship between ACL reconstructive surgery and osteoarthritis. ACL injuries have become the most prevalent knee injuries suffered by athletes today. ACL stands for the anterior cruciate ligament. It is located behind the kneecap in the knee joint. It attaches the femur to the tibia. Its purpose is to prevent hyperextension, provide stability in the knee, especially in lateral movements. Over 200,000 cases are seen annually, with 1 in 1,750 people aged 15 to 45 having torn their ACLs. The injury occurs when the ligament is extended beyond its intended range, with surgery required for fixing. There are 3 graft choices for replacement. The autograft, which means it is from your own body, has 2 choices: patellar tendon graft, which is taken from the front of the knee, or the hamstring tendon graft, which is taken from the hamstring muscle and is oftentimes spindled together with the gracilis tendon to add added strength, or an allograft, which is taken from a donor body. Osteoarthritis is caused by the breakdown of flexible tissue at the end of bones. Its degeneration of tissue leads to difficulty in movement in the joint. Here I have pictured the knee area that shows where the patella is, the ACL ligament itself, as well as the femur above and the fibula and tibia below. The significance of the problem. Osteoarthritis has become the most common joint disease. It's said to have aged the joint by 30 years. It's usually diagnosed 5 to 20 years following the surgery to fix. 75% of people over the age of 65 have been diagnosed with this condition. It involves the breakdown of tissue causing the bones to rub onto each other. This oftentimes causes discomfort as well as swelling. The swelling then leads to loss of range of motion in the joint. In smaller tests done, the patellar tendon graft was found to have the most frequent diagnosis of osteoarthritis. Here I have pictured a healthy knee joint versus the knee joint with osteoarthritis. You can plainly see the scarring and the bone breakdown that can be very uncomfortable. The purpose of my study is to show the relationship between ACL reconstructive graft choice and osteoarthritis. I intend to see just how much each type affects the knee, short-term as well as long-term. I also intend to see if one choice has less patients with osteoarthritis. In that case, my hypothesis then becomes that the cadaver graft patients will less incur osteoarthritis. I also believe there will be a positive correlation between the patellar and the hamstring graft patients and osteoarthritis. I believe that patellar patients will have the onset later in life, and hamstring patients will have it earlier. My delimitations and limitations. Some of my delimitations include not testing for how much arthritis is present, only if it is or is not present, and only in the knee area. In range of motion measurements, I will only be able to take the measurements contralaterally since I don't have previous measurements of each patient. And the study will only be conducted in Orlando with patients located in the Orlando area. Some of my limitations include the inability to generalize the results for the full population of those affected. Also, the inability to study everyone possible, as well as the fluctuation between different people. Different situations affect different people differently. On to my literature review. 2 million people tear their ACLs annually worldwide. ACL is part of 3 ligaments that make up the inside of the knee. And these ligaments allow us at the movements that we do daily. Statistics show that females have greater ACL tears than males do. The injury has become so more prevalent than previously done in sports. Football, soccer, and basketball have all recently seen a spike in these injuries. The injury has even become seen in non-contact sports such as golf. The injury has become so recurrent that oftentimes people watching on TV can easily diagnose the injury based on the replay shown to us. After diagnosis, the patient then consults with an orthopedic surgeon. They will discuss which graft choice will be used during the reconstructive surgery. For the patellar graft, it is often considered the stronger route. It is taken from the kneecap area in the front, and the scar often resembles train tracks. The kneecap is moved out of place with 2 incisions placed, one on top and one below the kneecap, to get the new graft into place. Numbness is There is some numbness present on the front of the kneecap near the scarring, and the deficit is then seen in knee extension due to this route. When going with a hamstring graft, strands of the hamstring are taken and are often spindled together with the gracilis tendon to add added strength to the graft to prevent future tearing. Full muscle is had for the leg extension, however, the deficit now exists with leg flexion. Cadaver graft is taken from a donor body and can be any ligament or tendon deemed strong enough for this. It can be a patellar or a hamstring graft from a donor, as well as a gracilis, Achilles, or even a semitendinitis. It has the shortest rehabilitation time due to no muscle damage to be used as a new graft, just the replacement of the torn one. Its major drawbacks, though, include the prevalence of rejection of a graft due to being from a foreign body. And it is also often considered the weakest graft choice, with 73% of autograft patients returning to pre-injury activity, but only 65 of allograft patients return. The allograft patients often complained of retropatellar pain. The rehabilitation process. Patient begins 2 weeks post-surgery in a straight leg brace. They are barely able to bend the knee. The purpose is to bring back the full muscle strength and range of motion back into the knee area. As the weeks pass, the patient begins to ride a stationary bike, walk, even jog and run to begin the process of getting back to pre-injury levels of activity without compensating using the other leg. Biodex is a machine used to test the leg strength and flexion and extension to show the deficit compared to the uninjured leg. The machine uses sensors throughout motion to show if and where the deficit occurs, as well as showing if there is a jerking motion throughout the movement. Physical therapists want to see the fluid motion throughout the whole range of the movement, and when less than 10% of a deficit is seen between the uninjured leg and the injured leg, the patient is then cleared from therapy. Here I have pictured what a Biodex machine looks like. When on the Biodex, this is the graph that will be shown on the screen. You can plainly see that there has been jerking motion through it when they want to see a basic fluid arc on full range of motion. Osteoarthritis has become the most common form of arthritis today, with 6% showing symptomatic signs of the disease aged over 30. It becomes more prevalent with age, and tasks such as sitting, standing, walking, and climbing stairs often become very difficult. It is the single most common reason for total knee replacements, and is characterized by cartilage loss, resulting in swelling in the area. It leads to major pain in the joint with movement, and also leads to the loss in range of motion. It's become very widespread in women, most notably those postmenopausal. Due to the widespread diagnosis in postmenopausal women, new discussions have arose whether hormones play a factor in this onset. It is believed that estrogen plays a role in the onset of osteoarthritis in women. There has been found an inverse relationship, however, between osteoarthritis and osteoporosis. Bony remodeling has become an effect of osteoarthritis and shows that osteoarthritis affects the knees in ways previously unexpected. Fortunately, pain from osteoarthritis only becomes noticeable upon movement. If the joint is unmoved, there is no pain had by the sufferer. The breakdown usually occurs from initial joint injury, allowing osteoarthritis to develop. The knee area alone diagnosis has become alarmingly high. The studies done on female soccer players aged 26 to 40 showed that 51% fulfilled the criteria to have an osteoarthritis diagnosis. The fact that this condition is seen under the age of 40 is quite alarming. Studies done to see if a difference in patients with osteoarthritis in injured knee alone versus both knees or just in the uninjured knee found that 64% of patients had osteoarthritis in the formerly injured leg versus the uninjured leg. The study was conducted on patients who were only 10 years post-surgery, but there was no difference found between the patellar graft and the hamstring graft patients. Obesity has also taken on a huge factor in the onset of osteoarthritis. Obesity has become a huge epidemic in the United States and has become a factor due to the increased weight now put upon the reconstructed knee joint. A study conducted found that people with a BMI in the obese category or higher had higher incidences of being diagnosed with osteoarthritis than those who had a BMI lower than obese. In younger people, obesity isn't always the case though, and full joint replacement is often considered but often seen as unsatisfying, as it has a higher fail rate. A new trend is to look into cartilage repair, which has seen a huge potential in pain relief and helps to prolong joint replacement until an age where it is most satisfying and has a higher success rate. Participants in my study will be 180 total volunteers, 90 males and 90 females, each group with varying grafts done and separated into different age groups. Young adults will be considered 18 to 34, adults will be considered 35 to 64, and senior citizens will be considered 65 years and older. Advertisements will be placed in orthopedic clinics, physical therapy centers, as well as signs and billboards all around town to gain interest in this study. The participant must have had an ACL reconstructive surgery. Any other knee tear will not be counted or play effect in the results of the study. If a replacement surgery has been had, the patient's information will be taken in the past tense as an affirmed osteoarthritis diagnosis. Patients who have had surgery on both knees will not be allowed in this study, as it doesn't give the researcher a non-injured leg to test against. The goal is to have an equal amount of patients in each category to represent fair results. The procedures. The study will be conducted in the Human Performance Lab at the University of Central Florida, located in Orlando, Florida. Participants will first be asked background questions to gain insight into the person and help find common factors. With the consent form signature, participants will be asked to complete minor testing, such as a lateral movement test similar to a shuttle test, a walking test, which is a 10-minute max walk on a treadmill, and biodex testing to see flexion and extension on the injured versus the uninjured leg. Instrumentation. Data collected requires different machines and instruments to be used. The biodex will be used for the flexion and extension tests to see deficit and range of motion loss. The treadmill will be used for the walking test. Tape, 5 lightweight objects, and the stopwatch will be used for the shuttle test. The time won't count against the participant, but the lap button will be pressed each time the person begins moving in the opposite direction than previous. We will then average the times of each direction to see if a deficit is had with an injured leg leading versus a non-injured leg leading. Excel will be used to enter the data into a clearly readable table, and SPSS will be used to find statistical correlations. My statistical techniques. Questions initially answered will be broken down into categories for better interpretation. Graft choice will be clearly defined, and pre-surgical and post-surgical activity levels will be broken down into 3 levels. Mild, with little to no athletic life, such as walking the dog, walking around the neighborhood or mall, or playing mild, strenuous activity once a week, such as golfing or bowling. Moderate, where a gym workout is somewhat frequent, jogging once or twice a week, or playing a pickup game of a moderately active sport or a non-professional league. Or high, which includes a large amount of vigorous activity or professional sports, working out more than 4 times a week, or those who work their body to the condition max multiple times per week. The patient won't be penalized if a change from pre-injury levels to post-injury levels is found. It's just using as a guide to see if the graft choice affects people's post-injury activity levels. Time since surgery will also be noted. During testing, the scores will be collected from the shuttle run, each lapse, treadmill, and results from the biodex testing will be entered into another table. Presented results will be shown from the merging the 2 tables. The first table shows how each participant will be listed with age, sex, graft choice, pre-injury level, post-injury level, and time since all clearly stated. The second table will then show the averaging from the shuttle run with the injured leg versus the non-injured leg leading, the biodex injured leg flexion and extension results, as well as the uninjured leg flexion and extension results. Then, how long they lasted on the treadmill with a 10-minute max. Using the SPSS software, Pearson product moment correlation will be calculated for each comparison based on graft choice. Values will be found between -1 and +1 to show a positive or no correlation. Strength of the relationship between the variables represent by value of p. P-value of -0.1 to -0.5 or 1 to 0.5 is considered a strong relationship. from negative zero point 0.5 to zero point 0.3, or from 0.3 to 0.5 is considered a moderate. Negative 0.3 to 0.1 to negative 0.1, or 0.1 to 0.3 is considered weak, with a range of negative 0.1 to 0.1 being none, or not, or very weak. Here I have listed the references that I used for this project. I wanted to thank you for your time in considering allowing me to do this project. Thank you all again. Have a great day.